We'll then move on to Professor Avi Schroeder from the Technion in Haifa. We'll give a lecture on a very innovative approach for personalizing medicine via barcoded nanoparticles. Avi, please.
Thank you, Twan. Please allow me to start by congratulating you for the Young Investigator Award. I mean, we're all very proud. Thank you very much for being here today. And I've been at the Technion for 2.5 years. And we work on drug delivery systems that are based on lipids, mainly liposomes and lipid-like assemblies. And throughout my rather short career till today, I would say one thing I've learned is that we have to tailor drug delivery systems for each application, meaning each disease would probably need to be tuned, or the delivery system would have to be tuned for the disease we're trying to treat. And we learned it also first in the clinic. So, on the top of the slide, you can see a lipid-based system that's used for treating osteoarthritis, and it's injected intra-articularly. It reduces friction and wear in patients. And here we have no drug. We're looking at the lipids as biomaterials. They're not nano. Actually, we found here that micro is better than nano, because micro stays on the surface of the cartilage, and nano will actually penetrate deeply into it. Moving on to siRNA delivery, we saw that we need very small particles that encapsulate the RNA in a manner that will protect it en route, but also release it at the disease site. And there we had an interesting twist when we were dealing with nanomedicine. We were trying to treat lung cancer, and interest actually came from the agricultural field with these systems, and we're using drug delivery systems that we developed for people actually today to treat shrimp in the lab and treat shrimp disease. So sometimes applications take a slight twist that addresses a need that exists at the same time. And underneath that is a presentation I gave a couple days ago here of particles that can actually produce a protein. They can synthesize drugs on site inside the body upon an external trigger. And I won't be discussing these systems today. I will be discussing the field of cancer, how we can use nanotechnology to maybe determine which medicine will be best for each and every patient. And I'd like to start with an image taken from Harrison. And it wasn't shown here earlier in this conference, but Twan may be showing it later on. And I think it was one of the first examples that nanotechnology can really accumulate inside of tumors. And we're looking at 3 different patients: one with a tumor at the base of the tongue, a patient with breast cancer and local metastases, and a patient with lung cancer and metastases to the bone marrow. And all these patients were actually injected 100 nanometer liposomes with a contrast agent, and we can see the robust accumulation at the tumor site. And this was explained by Maida. This is a paper by Gabizon, who's sitting here in the audience. They actually showed that the blood vessels are different in the tumor site and in healthy site. And today we know that this surely isn't correct for all tumors. It's probably not correct for all patients, and it surely varies from one situation in a disease to another situation of the disease. And we know that translating more and better nanomedicines to the clinic will have to address this issue. We did take advantage of the EPR effect for the technology I'll present here now. And mainly one issue we asked ourselves is, can nanomedicines actually accumulate in sites of metastases? And we know once a primary tumor starts sending these small nodules to other regions in the body, that's where nanomedicine can actually give a great impact and address the need of treating many different sites of disease simultaneously, and without harming other regions inside the body. The models we use in the lab are mouse models, and you can see here 2 metastatic models that we've been working on. One on the right-hand side of the screen is of metastatic melanoma. This is a mouse from the inside. You can notice the liver, and above it is the lung. And inside the lungs, you can actually notice the nodules of the metastatic melanoma out of the word melanin. On the left-hand side of the screen, It's metastatic breast cancer. This is triple-negative breast cancer lesions in the lung of biopsy mice. And we wanted to ask, can we actually improve treatment using nanomedicine? And specifically, what we found is that nanomedicines actually grant an enhanced residence time in the metastatic lungs. So each image here actually shows either a free dye or an encapsulated nanomedicine dye in metastatic lungs. And while during the first hour, for example, after 3 or 6 hours, you can see accumulation of the free dye on the left-hand side of each image, the nanoparticles start accumulating over time in the lungs, granting us a wider window for treating metastasis at the disease site. So we do believe metastasis, not only for the primary tumor, but also for the metastatic dissemination, will grant us new applications. And the question we wanted to address is, could we use nanotechnology not only as a drug delivery system, could we use it as a probe for testing the efficacy of drugs inside of patients? And we looked at each nanoparticle as a small gauge for testing the efficacy of a drug. And I think we all remember House looking at a patient and determining which medicine or which prognosis is appropriate for this specific patient. However, in real life, we know it doesn't really work that way. And in fact, reports show that at least 30% of cancer patients are prescribed an ineffective medication, meaning a medicine that doesn't work for them. And one of the questions we had, could we maybe aim better? Could we predict in a better manner which medicine would be best for each patient? So we surely didn't invent this approach. The approach of using a personalized medicine is widely used today in the clinic. A patient would come, a biopsy would be taken from the cancer lesion, and then it can be sequenced or biomarkers can be sought. But that brings us only to the 30% that we saw today, or 70% of accuracy. And the reason is that most likely genetic markers may not give us the full picture of how a patient will respond to a medication, or we may not understand all of those features as well as we hope to. So a second set of technologies kicked in, and here a biopsy is taken from the patient, it's expanded in the dish, and then different medicines are screened against that biopsy inside of the dish, but lacking the tumor microenvironment. And once the cancer cells actually see plastic, they respond differently than they respond inside the patient's body. So if we're lacking a microenvironment, what we can do is we can implant a biopsy from the patient in a mouse, and then expand it in the mouse, and then screen different drugs against the biopsy inside the mouse's body. This technology is actually very good. The only problem is that it takes too long. Usually it takes around 6 months for a result to come back for a patient saying this is the best medicine for you. And for most patients, or for many patients, it's just too long, and in some cases also too expensive. So we asked ourselves, can nanotechnology maybe kick in this space and grant an added value and maybe better sensitivity than the current technologies have? So we asked ourselves, can we screen drugs inside a patient's body? Can we use each and every patient as a laboratory for testing the efficacy of drugs inside the patient's body? And we didn't invent this approach. It's been used for many, many years in allergy screening. And you can see here the young child, and different allergic markers are actually injected in at very low doses, and the response to each and every one of these allergens is being tested inside the patient. But in order to mirror this approach inside a patient, we could go for the low dose. However, one thing we lack is this grid system the physician marked on the patient's back. And we had to add a grid system, and what we did is we added barcodes to each and every drug we're going to inject into the patient. So our approach was to take nanoparticles that are used today in the clinic for administering drugs, and then loading each one of these liposomes with a very low dose of a drug together with a barcode. And the barcode is specific to each and every drug. And the reason we chose DNA as our barcode is because DNA can actually be detected at single cell sensitivity. So we needed sensitivity that's far greater than the sensitivity chemical assays grant. And our approach is to inject multiple nanoparticles with different drugs into the patient at the same time at a very, very low dose, namely a nano dose of the drug. So this would be the loading of the drug in the barcode. And the barcodes we saw are approximately 50 to 150 base pairs long. And the reason we chose double-stranded DNA at this length is that it was rather stable in all our in vivo trials, meaning for the time of the assay, we saw we could retrieve the DNA barcodes from the cells and from the cancerous tissue over time. And our approach would be, again, utilizing the enhanced permeability and retention effect. Particles would be injected with different drugs and corresponding barcodes into the circulation. They'd accumulate at the tumor site using the enhanced permeability and retention effect. And then, actually 48 hours later, a biopsy would be taken from the tumor. The biopsy would be broken up into a single cell suspension, and then we would separate the cells. For example, we would look at the live cells and the dead cells. We'd look at the barcodes we have in the live cells, and we look at the barcodes we have in the dead cells. And that teaches us which medicine is effective and which medicines are not effective in this specific patient. So at first, we went to see that we could actually detect our barcodes. And if you take a large ensemble of cells, you can detect them rather effectively. You can see on the left-hand side 10,000 cells or 500 cells. And then going down to a single cell, looking how different drugs actually affected a single cell, we had to improve the single-cell PCR assays, and we developed a technology around that enables us detecting the particles in each and every cell. And this is what it looks like when barcoded nanoparticles actually enter a cancerous cell. You can see here these are the barcodes actually inside of a triple-negative breast cancer cell in vitro. So we wanted to test it in vivo to see if this approach would actually work, and we injected 5 different compounds, 2 control compounds and 3 anti-cancer compounds. So the 3 anti-cancer drugs, cisplatin, doxorubicin, and gemcitabine. So if we take cisplatin and gemcitabine, what you can see is that we found more cisplatin barcodes in the dead cells in comparison to the live cells. However, if we compare gemcitabine to cisplatin, what we can see is that for each 5 dead cells we find cisplatin in, there's only 1 live cell with it inside. However, in gemcitabine, for each 6,500 dead cells, we'll find only one live cell, meaning that gemcitabine in this tumor, in this mouse, is actually far more effective. And when we asked the physicians why doxorubicin, for example, was less effective in a triple-negative breast cancer, many of them told us that in triple-negative, doxorubicin would not be the first choice of treatment, and that actually surprised us. So probably caffeine wouldn't be our choice of treatment in this case. However, one issue that was raised many times in this conference is that the physicians are getting more and more data and not enough information, meaning they don't have time to distill the data they get into information that could be valuable. And what we wanted is an assay that would grant the physician our recommendation, what we see inside the patient, and then the physician could actually decide which medicine would be best. And in this case, what we'd give them is a potency graph that would show, for example, here, gemcitabine is more effective than cisplatin, is more effective than doxorubicin effector, and of course more than caffeine or just than any other placebo. So this would help the physicians make a better decision in time. And we tested the ability to predict a drug on the treatment, and you can see here mice that were treated according to their prediction, and looking at the different tumor sizes. So gemcitabine really granted, in this case, also the best prediction and also the best therapeutic outcome. But this wasn't only it, because if we compare the size of the cisplatin tumor and the size of the gemcitabine tumor, they actually look rather similar. But when we looked at the pathology of the different tumors, we actually saw a huge difference. And while the cisplatin tumor is far more dense, more active, and the gemcitabine tumor is actually on the way to general remission and far better therapeutic outcome. And you can also see here what the control medicines granted inside. So that's not the end of the story. We'd actually, when we think of cancer medicine, we wouldn't want to look at the tumor as a whole. We'd actually want to look at each and every cell type, and we want physicians to strategize how they're going to approach the cancer. Are they going to first treat the cancer stem cells, or are they going to first treat the bulk, the tumor-associated macrophages, or the bulk cancer cells inside the tumor? And those are the tools we'd want to give them. So we'd actually be able to tell them, in this cell type, this and this medicine would be best, and maybe you want to try and start with this and not with another medicine. So why is nano important here? One thing we saw very, very clearly is that small nanoparticles don't penetrate the tumor site. Penetrate the tumor site, while micron-sized particles just stay outside. So nano here isn't only a code, and that kicks back into Harrison's image earlier on. The Technion made this short image. I think it explains it better than I do. These are barcoded nanoparticles entering the tumor through the enhanced permeability and retention effect. And then the barcoded nanoparticles will enter different cells inside the tumor, dispatch their drug and the barcode, and grant the therapeutic outcome we're looking for. So each medicine would actually respond differently. So I'd like to end here and just thank a wonderful team of students. Most of these are undergraduate students that are working with us. Some are graduate students. Thank you very much for listening. Thanks.
Thank you for sharing this very exciting concept with us. I'm sure there are questions. Yes.
Very nice talk. I see a kind of problem. Maybe you solve it. So all the different drugs, they have different physicochemical properties. Right. And they may not mix equally well with your barcoding. The other thing is that when you make this mixture, it could be that what you are seeing also are synergy of different drug combinations. So how can you solve these two issues?
Yeah, so absolutely. The first I would say is a challenge, and the second is an advantage. So the first issue is the different pharmacokinetics different drugs have. And the way we approached it is just loading different levels of the drug into the particle. For example, if we have a drug that we know will release slightly slower from the nanoparticle inside the cell, we'll probably load more of it into the nanoparticle when we inject it in. The second thing is synergy. So one, we don't want too much synergy because then the mathematics just become impossible, but we do want to also see synergy inside the tumor, how two drugs would work. And we have two ways of approaching it. So one is having two nanoparticles with the two different barcodes that enter a cancer cell simultaneously. And then when we measure that cancer cell, we'll see to the two peaks of the barcodes inside that cell. Another way of approaching it is by having one barcode for two drugs that are actually inside the same nanoparticle. So those are two ways we approach it. And that's just one side of this coin. And the second side is really the mathematics behind the system. So we calculated ahead of time, and I have to say many of our initial experiments did not work, is we calculated approximately how many of our particles will reach the cells inside. Not the microenvironment only, but will actually penetrate the cancer cells. And that's the amount, that's the dose we inject. So we inject a very low dose of the nanoparticles, so we know each cell has, number-wise, less than 4 particles, because then the mathematics are still possible and we get very, very good data. One advantage I think we have here is that even in a 1 millimeter biopsy, we have millions and millions of cells. So it actually grants us a lot of data points at each site. And if I take this, we usually took between 6 million to 30 million cells from each tumor, and we assayed each and every one of them to know which medicine would work. Yeah.
One more?
Yeah.
2 more. Okay.
You have, it looks like a very elegant approach, my compliments, but it's still, and you addressed it a little bit in your last part of your answer, it's against my gut feelings how nanomedicines work, because it seems to rely on internalization of your nanoparticles by cells. Right. I do not exclude totally that it is impossible, but generally you would need a targeting ligand or so to improve internalization by cells, and nanoparticles are not at least by most cells, not easily taken up. So is this a major drawback, or do you just rely on a few cells which do this, and then that's enough? How do you see this?
Yeah, so thanks for the question, and I have to say that was the thing that worried us most when we started the study. However, I took evidence from other work we did with siRNA. So in siRNA delivery, for example, there's no question the nanoparticle brings the cargo into the cell. And what we assumed ahead of time, meaning that a nanoparticle doesn't only reach the tumor microenvironment, it has to also ferry the cargo across the cell wall, which is actually also true here for our barcodes, because the barcode itself cannot penetrate a cell because it's a DNA barcode if it's not inside the particle. And when we looked at it, the calculations were, we said that if we take the enhanced permeability and retention effect, probably 6 to 7% of our injected dose will reach the tumor. And then from that injected dose, what I assumed at the time was that 90% of the particles will stay outside in the extracellular matrix, but 10 or 5 to 10% will enter the cells. And that's actually the number we found. So we measured that several times, and we see the uptake of approximately 5% of that 6 to 7% inside the tumor cells. Regarding the uptake by different cancer cells at the tumor site, I fully agree with you, meaning that nanomedicine may not actually accumulate in different cancer cells or different cells of the tumor microenvironment in a similar manner. And several of the talks here talked about it, that nanoparticles will accumulate maybe more in macrophages, but we surely see them also we see them in different cell populations. I showed here 4 cell populations that we have, that we measure the barcodes inside each and every cell part. And it differs from one cell type to another. However, we get enough signal in also the lower signals in order to get meaningful data. And I think the concept we had of release outside the tumor cells and not inside the tumor cells is correct in general. However, in this case, we see that we have also, and also in other cases, we have a portion of the particles that are also taken up by the cancer cells. Yeah.
Alberto, last question.
Yeah, hi. Congratulations on this original work, Avi. I have a question and maybe a comment that follows Gert's remark. And I think that in order to take full advantage of your system, actually, you could very well envisage, and usually I'm against this approach for therapeutic purposes, but for diagnostic purposes, direct intratumoral injection would get you rid of any need for a stealth nanoparticle. You could make much more easily internal particles that can be internalized, and then your system can work maybe at a very high efficiency, and you can actually biopsy the same area in which you have introduced your probe. So I think this could amplify the advantage of your system.
Thank you. I appreciate that. That's a great recommendation. Thank you. Thank you.
Okay. Thanks again.
Thanks.
Twan, shall I introduce you? Well, you can if you want.
Okay. So it's my great honor and privilege to introduce Professor Twan Lammers from Aachen, RWTH Aachen. Twan is, I think, one of the, not only I think, actually the CRS just recognized that, is one of the leading scientists in the field of nanomedicine and drug delivery today, looking, I think, at the hard questions we have in how nanomedicine would actually be effective and where nanomedicine may not be the best choice. And Twan isn't ever afraid to ask those questions. That's what really makes him such an amazing scientist. Twan, please.